Hello, everyone. I am Dr. Tawab Khalil, co-chair of ISPRM Communication Committee, and today I have a very special guest. You can just tell, you can guess from my smile that today we have none other than the Professor Walter Frontera, and I'm just so excited to have him here with us and to talk about aging, functioning, and rehabilitation. Welcome, Professor Frontera. How are you doing today?
Good morning, good afternoon, good evening. I am doing very well, and thank you very much for this opportunity to talk to you about what I consider to be a very important topic, not only personally, but also for the specialty of physical and rehabilitation medicine.
So, Professor Frontera was actually the chair of a workshop on aging, functioning, and rehabilitation that was conducted in the February of 2024. And so, we will be talking a little bit about that as well, but then generally, we will be talking about aging, functioning, and the role of PRM in that. So, Professor Frontera, what actually motivated you to focus on the intersection of aging and rehabilitation?
The intersection of aging and rehabilitation,
Yes.
in my opinion, is a very important one. Um, the as you well know, the number of people and percentage of people in this age group that we call the aging group, older adults and so on, is increasing. This is well demonstrated by WHO statistics, and it is happening all over the world with very, very few exceptions. So we're going to see in the future a significant percentage of the population of the world in this age group, both men and women. Some estimates, for example, that have been published show that in some countries, one third to 40% of the population will be in this age group. If we consider the world, the population of the world, it may be somewhere between 20 and 25%, which is a very, very large number. Now, we all know that older people, as we grow older, we develop impairments that are associated with the changes, the biological changes that accompany aging. And so those limit the ability of individuals to do things, to participate in activities and the things that they want to do. They lose independence because of that, and they usually come to health systems to get help more frequently than younger adults. And that is where our specialty can be of significant help. We should be prepared to address the issues that this population is confronting in terms of mobility and other elements of what we call functioning. I don't think there is a medical specialty that is closer to this topic and better prepared to help this population than physical medicine and rehabilitation. So I do see a significant interaction here. Aging is happening individually and as a society. Rehabilitation is the way we can help these people maintain a functional level and independence that they wish to have in their older age and so on. So in my opinion, this is a very important issue that we need to address.
Professor Frontera, you talked about the various physical impairments that are seen in the older adults. And what are the most prevalent physical impairments that we see in older adults?
I think the answer to that question really depends on our focus because there is a very high prevalence of sensory impairments, vision, hearing, and so on, which I think we need to be clearly attentive to and and incorporate in the rehabilitation process professionals that can address some of those impairments. From my perspective, it is mobility, the main issue. Of course, that that has a significant number of, um, I would say, consequences on aspects related to mobility that we need to consider individually. Um, but I would say that mobility is one of the most important expressions of aging that we see in our clinics, and that rehabilitation is clearly a very effective intervention in many cases.
Are there any specific rehabilitation techniques that are most effective for improving mobility and independence in this specific patient population?
Well, I think that we have in rehabilitation a large number of interventions that may be helpful depending on the underlying cause of the mobility problem. Of course, in part because my research is related to this, I consider exercise to be one of the main interventions. And to a significant degree, exercise is independent of the underlying cause of the condition. But it is well accepted, it is safe, it is effective, can be combined with other interventions, pharmacological, other kinds of therapies, and so on. And it is also accessible to a lot of people, and it is not an expensive intervention. So there's a lot of good things, a lot of positive things about exercise that we should consider. And as you will know, we can do exercise in different healthcare settings because patients that are in a hospital can exercise. Of course, it is a different type of exercise, but still, it is exercise. Patients in outpatient clinics and those who live in the community can join community based rehabilitation programs that focus on exercise. So, I would say that there is a large number of potential interventions. Again, like assistive technologies, devices that can be used to enhance mobility. But I would clearly emphasize the relevance and importance of exercise in this particular age group.
Yeah, so can you discuss the importance of individualized rehabilitation plans for these patients?
When we talk about many of these interventions, we tend to consider, I would say, the big picture. The general idea that exercise can be useful, the general idea that assistive devices can be useful, or any pharmacological agent. Um, but I think we need to understand that aging is not a homogeneous process, and there's a lot of heterogeneity in older adults, and that a single prescription, a single plan, intervention plan, may not work for everybody. And I think we need to pay attention to that. And even though you can, at the beginning of the interaction with the individual, perhaps implement an exercise program, for example, that that is kind of a generic program, I think we need to be careful with that approach. And I think we need to understand that that individual may have conditions that may make us change the exercise program. So, back to your question, that really means that even though we may start with a generic plan, we need to consider the individual nature of that plan, the kinds of exercise, the dosage, and so on that is particularly useful for that individual. So, I think that's a very important concept that we should never ignore. Is just not very different than when you adjust the dosage of a drug because the patient may be responding in a different way, or because the dose may be too high, too low, and so on. So exercise has the same requirements, And I also believe that assistive devices can also be put into that same category. You have to individualize the intervention. And of course, the more you get to know the person, um, the more effective that process will be. So it is important to get to know the individual who's consulting with you about what to do about a mobility problem and so on. So very, very important issue.
Professor Frontera, in your practice, what do you think that what are the exercise that are particularly, what are the actual types of exercises that are particularly beneficial for maintaining and improving the function in the aging population?
Yeah. So this is another way of looking at the at your previous question, the individual nature of the recommendation. And one way of thinking about it, not the only way, but one way, is to consider what is the nature of the impairment. What is the patient or the person having difficulty with? Is it balance? Is it flexibility? Is it cardiovascular function, aerobic conditioning, and so on? Is it strength? And once you define the nature of that impairment, then you can choose the exercise. And you have to to say to someone that you're getting old, you're older than most people, and so on. Therefore, you need to exercise. Is only the beginning of the conversation. You're not going to help the patient that much if you stop there. You have to be more specific. So if you're concerned that a particular individual who came to your clinic cannot, for example, rise from a chair, well, then the issue may be muscle strength of the extensors of the knee. And then the exercise prescription has to be strengthening exercises for that particular muscle group. If the concern is that the person doesn't have enough flexibility in the, for example, shoulder joint and cannot reach objects that are high in the kitchen, for example, then you got to work in terms of flexibility exercises. If the concern is falls, then you may have to address strength and balance as a combination. So I think what you need to do is, as you evaluate this person that is consulting with you, is it's try to think about that. Where is the impairment? What is the main problem here? Of course, you could argue that older people have problems in all areas, and that may be true. In that case, then the recommendation is a comprehensive conditioning program that includes exercises of different forms, different types. And that's when you can get into, for example, Tai Chi is a type of exercise that develops strength and balance and sometimes flexibility. So then you may include exercises that will address more than one of those physiological characteristics. So I would say that would be the first step. Of course, after you're done with that process, then you can be more specific about the prescription, how much, how frequent, and so on.
How is actually technology being used in physical and rehabilitation medicine to enhance the rehabilitation outcomes of aging population?
How is the exercise being used?
No, technology. I would repeat. So, actually wanted to ask you that how is the technology is being used in physical and rehabilitation medicine to enhance the rehabilitation outcomes for the aging patients?
Yeah. Well, technology is present in many of the things we do in physical medicine, in physical and rehabilitation medicine. So it's not unusual that we use technology in this setting as well. And as you well know, there's a large variety of devices that are included in the assistive technology category of the WHO, and many more that are not on that list. So there's different ways of thinking about this. One of them is um, like the name of the device. It is an assistive device. So you have problem with mobility, walking, and so on, then you can use a device that will help you do it, and safely, of course. And that's one way of using the technology. Number two could be the use of technology to actually enhance your ability to do the activity you want to do. So then the technology becomes part of the training. And that's where a lot of robotic devices fall under that category, but also devices that are being used for exercise training. Technology, some new, but also technology that has been around for quite some time, that is part of the training itself, not of the activity, but of the training. So there are different approaches to this. And of course, technology is also being used to evaluate the individuals, and to make sure you can measure the capacity of an individual to do certain activities. So that is technology, for example, that we use in a laboratory of exercise physiology testing and so on. So, so there are different ways of using the technology, and I think that um, the usefulness of technology will continue to grow. The presence of technology will continue to grow in what we do, and in all of those three examples that I gave you. Um, the other thing that that could be mentioned, of course, is that it is important to connect this with research and education. So we need to include technology in research, and the other way around, to research the technology to make sure that it is useful, appropriate, and so on. Because sometimes we have technologies that have been developed, and conceptually they may look like useful, very useful technologies, but they have not been tested in a clinical study, for example. And I think we should do more of that to make sure that these technologies benefit the individuals. And um, similar to that, I think that we need to make sure that when we train future physiatrists, that we teach them the importance of technologies, and the way that they can be used in the clinic. So there's an element there that is research and education. And by the way, um, the availability of devices, drugs, and technologies, and so on, is one of the building blocks of health systems. So, if we find that technologies can be useful to address impairments in older adults, then we should try to include them in our health systems. And of course, that gets into the area of convincing, financing, the people in charge of policy and financing and so on, that these technologies can be useful in the clinic.
So the aging population is normally being seen by primary care physicians as well, by geriatricians as well, and by PRM physicians as well. So what do you think is actually the role of PRM physicians in coordinating care with the primary care physicians and the geriatricians and other specialists?
Yeah. I think it is inevitable because of the growth in knowledge that we have seen over the last 30, 40 years. I think it is inevitable that different professions, medical specialties, and so on, will overlap with each other. And in my opinion, this is good for the patients. And what we need to do is make sure that we develop good working relationships with others that have knowledge that may overlap with ours, may not be similar, but may overlap and may relate to what we do. And I think it is beneficial for individual physiatrists, but also for the medical specialty to make sure that we work with our colleagues for the benefit of the health system and the benefit of the patients. And there's a number of medical specialties, to use that as an example, that overlap with what we do. In today's topic, for example, geriatrics is an obvious one. And I think we should be working more with geriatricians. They have a different focus, a different emphasis, different training um, than we do. So we can learn from each other, again, for the benefit of the patient. So I would say that individually we should do that in our systems. You in your hospital, me in my hospital. But I suggest that we should also do that as a professional society. So I think ISPRM, for example, should be reaching out to international associations in geriatrics and gerontology because we have um, areas of interest in common. And geriatrics is not the only example. Another way of looking at this is research again. If you're going to do research in today's world and try to answer questions that are relevant to what we do, you're going to have to collaborate with a lot of people that are not physiatrists because that's the nature of the questions that we're trying to answer. These questions are complex, are transdisciplinary, and the only way we can do a good job in our research is to work with people that have expertise in those other areas. So I think we should take this as a positive challenge and reach out to other specialties, work with them, get them to join us, for example, in our meetings and building those bridges so we can develop a much better interprofessional relationship.
I think that is a very important point that for the sake of our patients and actually for the betterment of our patients. So when there is overlap between specialties, it is always better to reach out and collaborate with your colleagues. So that will obviously result in better healthcare outcomes as well. And well, speaking about the challenges, so what do you think are some of the common challenges that are faced in PRM when working with the elderly population?
Yeah. So I think our specialty has grown tremendously and significantly in the last 30, 40 years. Just as a personal example, when I trained as a physiatrist, all residency training programs in the US and Puerto Rico were general programs, meaning we didn't have any subspecialty officially. And now in the US, we recognize 7 subspecialties. And those 7 have been developed in the last 25, 30 years. And to me, that's a demonstration. That is evidence of the growth in knowledge in our specialty, and also expansion of the scope of what we do, and the fact that a lot of people can benefit from rehabilitation out there. As you may know, this paper that was published in 2019 by Alarcos Chiesa and her group showed very clearly that in the world there's 2.41 billion people that could benefit from rehabilitation. So that should tell you something about the challenges that we're facing. Um, Number two, um, science is advancing at a very, very fast pace. And that is a challenge because we need to make sure that we keep up with all of those findings and new information and research and so on. And that is an individual challenge, but it's also a collective challenge. I mean, that's why we have publications and journals and congresses, so we can keep up with the new evidence that we need to use in our daily practice. Number three, the reality is that older people, just to focus on that population, have significant rehabilitation needs, but quite complex. These are not simple needs like we see, for example, in younger athletes that may have a single injury that is clearly identifiable and can be treated with fairly simple interventions and so on. Older people have complex medical problems, and many of the rehab needs that they have are combined, mixed with other medical problems. So the interventions have to be adjusted and adapted. And this is important because in a lot of research in the last 30, 40 years, a lot of clinical trials have not included older people. So, one of the challenges that we have is that we are extrapolating findings from clinical trials that were conducted in a younger population to our older patients. But we really do not know if the intervention that was tested in the younger population actually works in older adults. So that's an important challenge. The previous question that you asked me is an important challenge. The interprofessional relationships, the need to work with others, is an important challenge because sometimes medical specialties do not understand each other. And so we need to do a lot of education of our own colleagues, not only our residents and students, but also our colleagues about what we do. Number six, in many countries around the world, and I actually would say everywhere, health systems do not prioritize rehabilitation. And that is an important challenge. We need to get health systems to become stronger by including rehabilitation. And that is really what the WHO, the World Health Assembly resolution that passed in May 2023, is telling us. We need to strengthen rehabilitation in health systems. So those are some examples of the challenges that we have. In my opinion, those we should welcome those challenges. We shouldn't get frustrated because we have challenges, and we shouldn't consider this as a negative. I think these are positive challenges, and what we need to do is train more people to work with us and work with others outside of PRM and try to address those challenges in a positive way. So that will be our contribution.
Yeah, so speaking about the healthcare system, so there is a wide, I would say, differences between the healthcare systems that are there in, for example, higher middle income countries and then in the middle and lower middle income countries. And how do you believe that how can healthcare systems better integrate PRM to meet the growing needs of an aging society?
Yeah, yeah. I have to say to you, I've seen that. I would say comparison in terms of access to rehab services, comparison between high income, low middle income countries, and so on. Quite frankly, although there may be differences, I really believe that access to rehab is not ideal in any country. In any country, even in high income countries, that they may offer more services, perhaps access may be a little bit easier. Um, I do believe that this is a global, a universal need to enhance access, increase access to rehab services. Now, a lot of this questioning, in my opinion, is very national, very local, because the reasons why people do not have access to rehab services um, vary from country to country. And I think a very important step is to try to understand the nature of the health system in a particular country. How's the health system organized? Because this is really, when you define health policy, that's what we're talking about. How do we organize our health system to accomplish a certain number of objectives? How is the system financed, for example? What is the nature of the workforce? Uh, the nature of the infrastructure? The epidemiology of the country? The kinds of conditions that affect the population in that particular country. So it takes a lot of discussion about local, national issues to understand how to strengthen rehab, how to include rehab in health systems. And I think it is an interesting challenge. And quite frankly, National Society of Societies of PRM should get involved with this. Sorry. Um, I think we have to get our colleagues in PRM to get involved at the national level in the planning of services in health systems. Of course, this is not always easy to do, but I think we have to find a way of getting the voice of a rehab professional to be included in discussions about national health systems. There's a lot of challenges there, clearly. And finances is one of them, but not, I wouldn't say that this is the only one. In my opinion, in many countries, the discussion is not whether we have enough financial resources to develop rehab clinics. My concern is that in many of those discussions, there is no one around the table with rehab knowledge. So no one is telling the policymakers how rehab can be effective, cost effective, and useful for the population. And I suggest that that's one important first step. Our national societies, our individuals, individual physiatrists, academic departments of PRM should get involved at the national level in the planning of health systems, in the evaluation of health systems, and bring to that discussion the rehabilitation perspective.
I think that is very important because the way the healthcare systems work is actually, I would say, a different thing. Because as a physiatrist, that is something that you are not accustomed to, or you're not trained on how to influence the healthcare system or how to develop it, or, for example, how to give the point to the policymakers to develop some intervention or, for example, rehabilitation in the healthcare system. But for that, I think the first point would be to understand how that healthcare system works, and then the next points would be to, how you can sit with the policymakers and uh, tell them that how rehabilitation can actually improve their healthcare system, and eventually then accumulating the rehabilitation in the respective
I,
national systems.
yeah, I agree with you. I think if I want to influence um, my health system, I need to do two or three things before I can go to one of those meetings and talk to policymakers. I need to understand my health system. How is it organized and who's financing it and where are the gaps that I think um, um, we can fill with rehabilitation services. So that's one thing. Number two, I need to understand the statistics of my population. What is the prevalence and incidence of conditions that may benefit from rehabilitation? Now, if I have a good understanding of those two things, I may be able to go to a meeting with the health minister or the staff of the minister and explain why rehab is needed, how rehab can benefit, why is rehab cost effective, and how much of my population, the population that the health minister is supposed to be taking care of, can benefit from rehabilitation. So there's a lot of work that we need to do ourselves. And then we need to approach the people that are making those kinds of decisions, the policymakers. Now, that's where you can incorporate health policy and systems research for rehabilitation into the process, which is different than to do research in a laboratory setting or in a clinic. That's one of the things that the World Rehab Alliance is advocating for. So I completely agree with you. We need to do our homework, and then we need to put ourselves in a position that we can use to influence decision makers.
That is so true. So, so I would like to now just ask you that what are some of the key messages that you would like to convey to the audience about the role of PRM in aging and rehabilitation?
Well, there's a lot of key messages in my opinion, but one very important key message I think it's is I think we should be very optimistic about the future of PRM. And I think there is a growing need for what we do. And I think it's not only the aging population, but the older adult population is an example of that. I think there is a lot of high quality research that is being conducted all over the world and being published that will strengthen the knowledge base of what we do. I think there's a lot of opportunity in health systems globally. Again, this is what the World Health Assembly resolution means, and I think we should take advantage of that. That's an important key message. I think all of those who are in training, younger physiatrists and even older physiatrists like myself, should be optimistic about this, and we should feel motivated, encouraged, even more interested in what we do than before, because there's a lot of opportunities. So I would say to the younger people that may be listening to what we're talking about today is that we need for you to make a contribution. You have to get involved nationally and internationally to make a positive contribution to help us continue to develop this important field for the health of the population. And the aging population is an example of why we need to do this. But again, it is not the only example. We've used that today as a way of explaining why rehab is so important and so on. But and it is. This is an important segment of the population that will continue to grow. But it is not the only one. So if I were to um, recommend something to the younger generation, it is continue with your training, learning, and be optimistic about the future. Make sure that you contribute to the knowledge base and to the development of rehab services in your health system, and get involved nationally and internationally.
Thank you so much, Professor Frontera, for giving us so much insight regarding functioning and aging and the role of PRM in this patient population. And I'm highly grateful for you for your time. Thank you so much, Professor Frontera.
Thank you very much for the invitation. Look forward to seeing you next year at the ISPRM World Congress in Jordan.
Yeah, yeah, that is going to be in Jordan. Yes, for sure.